Hello, I'm Kittrick, and I'm going to be doing endotracheal intubation. What is endotracheal intubation? Endotracheal intubation is an emergency procedure most often performed in patients who are unconscious or cannot breathe on their own. It helps to prevent suffocation or obstruction of the passage of air. This is often done in the hospital setting, but it can also be done by paramedics in the field. It's just a medical professional puts a tube into the trachea to allow for easier ventilation. Allows a safer form of ventilation because the air goes directly into the lungs, and the ET tube has a cuff on it which allows it to block off the trachea, so no vomit or any other stuff can get down into the trachea. Some advantages of intubation include isolates the trachea and permits complete control of the airway. It channels the air directly into the trachea. It eliminates the need to maintain a mask seal and permits administration for medications. And trachea is basically the windpipe. It's a cylinder tube that is about 4 inches long and about 1 inch in diameter. It begins just under the voice box and descends behind the breastbone, and it divides into two smaller tubes. Then each tube connects to each side of the lungs. Some medications that you can put down the ET tube are Narcan, atropine, vasopressin, epinephrine, and lidocaine. The acronym NAVAL could help you remember that. Although it is kind of a last resort to put any medications down the ET tube because they go right to the lungs, and obviously you know that fluid in the lungs is not good. It eliminates the need to maintain a mask seal because the ET tube is going to come straight out of the trachea and can easily be hooked onto a ventilator or a bag valve mask, or the bag. So there's no need to worry about getting a tight seal. Some disadvantages of intubating a patient are it requires specialized equipment, requires direct visualization of the vocal cords when you're putting the tube in. It can be very time consuming and requires considerable amount of training and experience, and potentially airway trauma. Like I said, requires a vast amount of training and experience. This is not something you just learn and are proficient at after doing it a few times. It takes many attempts and practices to become proficient. Potential airway trauma: every time you try and you rub your tube up against the esophagus, or the trachea, could cause it to inflame and make it swell shut. So it's always a hazard. And some equipment that you need: obviously you're going to need a laryngoscope, a handle, a blade, which it could either be a Mac or a Miller, an ET tube, and a stylet to go inside that, a 10 milliliter syringe, and some device to hold the tube. Obviously you're gonna have suction ready. Maybe need lubricant. And up here in the top left corner is a laryngoscope with a Mac blade on it. Here's the difference between a Mac and a Miller. A good way to remember is a Mac, a C in Mac, kind of a curve. Miller, on the other hand, the L is straight. Here's an ET tube with a stylet. The stylet is like a thing that goes inside the tube, and it gives it form, so you can form however you want it before. Here's a syringe, a 10 milliliter syringe that will be used to inflate the cuff after you properly get the ET tube down the trachea. When you're placing the ET tube, this is just a quick rundown, but obviously you want to, before you start law, you want to visualize the patient. Use a BVM ventilation with 100% oxygen. You definitely want to avoid aggressive hyperventilation, because that'll defeat the whole purpose. You want to prepare your equipment before you start. Make sure you have everything that you need on hand and ready, because once you attempt to intubate, the patient is not breathing. Then you want to consider a backup plan, like what am I going to do if for some reason I can't get this in. Have that ready. You can apply the cricoid pressure and insert the laryngoscope, which is just pressure right on the neck. It'll help lower the vocal cords so you can see them better. You might have to have a partner apply pressure while you're looking. Once you visualize the vocal cords, then you can start to insert your tube. You want to get the epiglottis out of the way, depending on what type of blade you're using. You want to be able to visualize the vocal cords and put the tube right through there. Once you see the vocal cords, you don't want to take your eyes off that. Once you do have it in the trachea, you want to inflate the cuff, ventilate, and listen for sounds. Make sure that you are in the trachea. Look for chest rise and fall. You want to confirm the placement with EtCO2 detector capnography to just make sure 100% that you are actually in the trachea, not down in the stomach. Once you are 100% sure, you can then secure the tube. There's the different types of devices you use to secure them. And then once you do secure, just again triple check that it's in the correct spot. If you're unable to intubate the patient, you should definitely have a backup plan. There's many different ways you can still ventilate the patient and not letting the patient be intubated. You can bag the patient with an oral adjunct or nasal adjunct. You got the King LT and the combi tube. These are all three significant options if you are unable to get the trachea or get the intubation in correctly. Up in the top left, there's a combi tube. Here in the middle of the screen, there's the bag valve, and on the bottom there is King LT. Like I said, this is one of the more dangerous things paramedics can do, because you are essentially stopping the patient from breathing while you take the time to get the patient intubated. Thanks for listening. If you have any questions, let me know.